Okay, Assalamu alaikum. Today we will discuss about the anatomy of the trachea and the esophagus. The anatomical features, I will be to divide the lectures into major parts. First of all, we will discuss about the trachea, and secondly, we will discuss about the esophagus. The trachea, we will talk about the major anatomical features and most important radiation which is related to the trachea, and also the blood supply, lymphatic drainage, and specific clinical considerations. And the esophagus also will go through the anatomical features, blood supply, and the clinical considerations. In the trachea is the cartilaginous tube, or you can say also musculocartilaginous tube. We have a little bit muscle fibers which connected or extend from the level of the larynx superiorly and downwards until to the level of the bifurcation of bronchi to the lungs at the level or in the thoracic cage. That means from the level of the neck downward to the thorax or the inlet of the thorax specifically. Then the length of the trachea about the 10 to 13 centimeter. There is a little bit shorter in female more than male, and also begin at the level of the C6. That means from the lower border of cricoid cartilage, and terminated at the level of the trachea by the carina. Carina is the landmark of cartilaginous structures at the level of the bifurcation of the trachea into the right and left bronchus. So okay, the the carina is the terminal part of the bifurcation, and this bifurcation has a different levels. Actually, normally in the cadaver about the level of T4, but in the living body, according to the continuous respiration, the level or maybe extend until to the level of the C6, and in the neonates and children about the level of T3. That means little bit above, so that there is a little bit variations in the level of the bifurcation of the trachea according to the individuals also, and also according to the gender. Then what is the importance of the carina? The carina is the anatomical landmark, act as a guideline for the surgeons during the endoscopy or through any intratracheal examination to check what is going on inside the tracheal tube. Then it's appear as the inverted shape or inverted Y shape under the mucosa at the little bit white color more than the adjacent submucosa or the mucosa of the trachea internally. And then after that you can see the most continuation or the most continuous part which act at the continuation of the trachea downwards in the right bronchi, and the dilated one in the left bronchi. So it's easy to differentiate it between them. Then okay, the major structures of the trachea anatomically it consists of the about maximum 22 C-shaped cartilaginous part. As you see here, this is the C-shape cartilage along the anterolateral aspect, and also consists of the trachealis muscles. The trachealis muscles have the longitudinal course along the posterior aspect, joining the two arms of the C shape of the cartilaginous part. That means completely make the closed of the C shape into the complete D shape. So these the outline of the cartilaginous part or the major structural part of the trachea. Then we have the lining epithelium. As you know, is the respiratory epithelium. The respiratory epithelium is the pseudostratified columnar epithelium with goblet cells. As you see here, there is glandular or gland which is responsible for the mucus secretion in this area. Then about the diameter, it's about 2 centimeter in the 2 centimeter in the male, a little bit less in the female. Then also the lumen is about 3 millimeter, and there is a differences according to the age. We have in the children about 13 millimeter, while in the female about 21, and in adult male about 25 millimeter. So the wall itself, the thickness of wall itself about 3 millimeter thickness, so that there is a little bit thick, specifically at the level of the cartilaginous part, more than the posterior aspect of muscular part. Then the major important relations in the trachea, we have the anterior and 2 lateral side, and also posteriorly. Okay, the most important relation commonly along the anterior aspect more than the posterior aspect. As you know that the posterior aspect, most of the posterior aspect related to the area between the trachea itself and the esophagus, which called the groove between trachea and esophagus. And this is at the dead space to facilitate the swallow of the food, and also to facilitate the dilatation of the trachea during the processing or during the coughing. Then anteriorly, specifically, there is different features you can find during or in the examination of the children. I mean, from these 3 years until to the 12 years. Okay, the left broncho or brachiocephalic vein. The left brachiocephalic vein, as you know, that has the courses from the left to the right directions to reach the superior vena cava behind to the sternum or manubrium sterni, so that in the children commonly this little bit raised up at the level or little bit at the level above to the manubrium sterni or at the jugular notch. So also the thymus gland. The thymus gland also most clearly most developed in the children, and you can see the lobular part of the thymus gland along the anterior aspect of the trachea, and we have the brachiocephalic artery on the right side. You can see it also most clearly, and you can become little bit most dominant of the anterior structures which related to the trachea in the kids. Then the posteriorly, the esophagus and the recurrent laryngeal nerve, and also we have the recurrent laryngeal nerve from the left side and from the right side, ascend upwards on both sides, and lies in the group between the trachea and esophagus to supply these structures, glandular structures, and also the muscular structures of the trachea. Laterally, that means on both sides, related to the loops of the thymus gland, common carotid artery, and the branches from the common carotid artery, and specifically the inferior thyroid artery, which has specific role in the arterial supply of the trachea. Then in the level or mostly or specifically in the thoracic part of the trachea, we have the sternum, that means the mammary sterni, and the thymus gland, sometimes the remnant part of the thymus gland, the left brachiocephalic vein, as I mentioned it before, and also the origin of these important arterial branches, the brachiocephalic artery and the left common carotid artery and the arch of the aorta. That means commonly related to the area of the arch of the aorta behind to the sternum in a specific area which called the superior mediastinum. The superior mediastinum, the most crowded area, which has important relation to the trachea or to the terminal part of the trachea at the level or before the bifurcation of trachea in the thoracic part of the trachea. Posteriorly also has most important relations related to the most the arch of the aorta and the left common carotid artery and left subclavian artery and also the left vagus and the left phrenic nerves and the pallura. That means we have the on the left side, and also in the right side we have the same, the right common carotid artery and also the right subclavian artery and the right vagus and the left phrenic nerves. That means parallel on both sides and also crowded in this area. So the nerve supply of the trachea, we have the sympathetic and parasympathetic innervation. The sympathetic innervation from the recurrent laryngeal nerve, the branch of the vagus nerve, and then ascend upwards behind to the trachea, and the groove between trachea and esophagus are responsible for the motor innervation for brachialis muscles, and also secretomotor for the glandular tissue inside the submucosa of the gland of the trachea, and sensory innervation to the mucosa or to the mucous membrane. Then the sympathetic innervation, as the preganglionic fibers come from the segmentation of the spinal cord in the thoracic 5 and 4, and also the postganglionic received from the middle cervical sympathetic ganglion, and this act as the vasomotor for the blood vessels around the area of the trachea. Okay, and also has specific role downwards in the bronchiolitis. Then the blood supply and lymphatic drainage of the trachea, as you see here, the tracheoesophageal branches, which has specific anastomosis in the free manner downwards. That means to make the network of arterial supply along the wall of the trachea. We have the branches from the inferior thyroid artery, and also there is a branches from the superior thyroid artery to supply the anterior to the isthmus and also the anterior aspect of the trachea. And then we have the branches from the internal thoracic artery near to the level of the bifurcation, and specifically the inferior bronchial arteries, which ascend upward to supply the terminal end of the trachea, so that we have a network of arterial supply. And you must take care about the surgical incision during the or inside the trachea, because we need to prevent the complete cutting of the major source of arterial supply along the length of the trachea from the cervical courses until to the thoracic courses. So the venous drainage commonly, or the main venous drainage along the left brachiocephalic, and also the lymphatic along the tracheal or pretracheal lymph node and paratracheal lymph nodes on both sides, and continues to the cervical or to the deep cervical lymph nodes. So we have the as you see here, this is the anastomosing along the area of this is the branches or tracheal branches, and the major sources of the tracheal branches, as you see here, from the internal thoracic until to the level of bifurcations, and also the inferior branchial arteries to supply the area of the carina, and superiorly we have the branches from the superior thyroid artery, and also the first branches come from this area to supply the area of the trachea along the posterior aspect, and there is a continuous anastomosing along the length of the trachea. The major important clinical consideration related to the area of the, or to the open the pathway or the passage of the air through the tracheostomy. In the tracheostomy, the surgical, the saving surgical procedures done in the case of the laryngeal obstructions, and commonly done below to the level of the thyroid gland, and also to the specifically the isthmus of the thyroid glands and along the anterior aspect of the trachea, then to be inserted or open in the vertical direction to prevent the continuation of the arterial anastomosis in the area anteriorly, and also at the level or between the second and the third cartilage or tracheal cartilage to insert in the tube, and then the respiration passes through the airway downwards to the bronchus. Do you have any questions here? I think that there is no questions, and also you can continue to the esophagus. The esophagus is the differ little bit from the trachea is the muscular tube, that means consists of muscles. Okay, and the length about 25 until to the 28 centimeter long. 28 is the maximum, but commonly is the 25 centimeter long, and the diameter about 3 centimeter, and extend from the level of the lower border or lower part of the pharynx at the level of the C6, and continues downwards until to the area or to the cardiac opening of the stomach at the level of T11. Okay, the newborn esophagus is about 18 centimeter, and also maybe end at the level of the T10. Okay, according to the length, and also generally the length of the esophagus is little bit. There is a variation or anatomical variation during the childhood until to the 3 years old, about 22 centimeter. So according to the course of the esophagus, you can divide the esophagus into the different parts. We have the cervical part, that means it's related to the neck, and thoracic part, and we have a small part in the abdomen about 2 to 3 centimeter in length, and end at the level of T12, T11 to join the cardiac or the stomach. The thoracic part at the longest part about 10 centimeter or 17 centimeter to 18 centimeter, and terminated at the level of T10 during the passage through the diaphragm, and also the cervical part from the pharynx downwards until to the level of the T1. Okay, about 5 centimeter in length, about 5 centimeter in length. That means according to the position. This the length most important for the esophagus during the courses of the endoscopy, so that the measurements must be according to the age, and also according to the gender. That means is it male or female. There is a little bit variation about 2 centimeter or 3 centimeter between the male and female. Okay, adult. Then anteriorly, the anterior relations related to the trachea, as you see here, okay, and then also related to the recurrent laryngeal nerve, which is most important on both sides, as you see here, between the trachea and esophagus, and posteriorly related to the vertebrae from C6 to the T1, and also extend behind. Also we have the dead space, which formed by the prevertebral fascia, and the longest colli, which supported the body of the vertebrae, so that posteriorly direct contact to the vertebral column. Then on each side, related to the lobe of the thyroid glands and the common carotid artery, also related to this area, and the thoracic duct. Thoracic duct commonly on the left side in the cervical part of the esophagus. In the thoracic part of the esophagus, anteriorly related to the perforation of the trachea and base of the heart, and also related to the structures which enter the hilum of the lungs, which called the roots of the lungs. Then posteriorly, the esophagus related to the, or from the first to the 11 vertebrae, that means for the long course, and then we have the thoracic duct slightly to the left side, and the longest colli muscles and fasciae along the body of the vertebrae, and on both sides we have the visceral surface of the lungs, which make a little impression on the visceral surface of the lungs, and descending aorta along the left side, and then we have the thoracic duct. That means posteriorly we have the esophagus on the right side and the descending aorta on the left side of the vertebrae downwards, and then the thoracic duct commonly lies between them, between both of them, between the descending aorta and the esophagus posteriorly. About the arterial supply. The arterial supply of esophagus also, according to the region, we have the cervical part. The main source of arterial supply is the inferior thyroid artery, which provide the esophageal plexus of arterial supply. This has a network continuous and stimulating along the esophagus, and also we have the downwards like the subclavian carotid artery, vertebral artery, ascending pharyngeal artery, and also we have the cervical and costo-cervical trunk at the branches from the area of the subclavian artery to supply the most terminal part of the cervical part. Then we have the thoracic aorta. The thoracic aorta supplied by the direct branches from the aorta or indirect through the bronchial arteries, which supply the lungs, and also we have the posterior intercostal arteries has branches to supply the area of the most posterior aspect of the esophagus. That means along the course, the adjacent arterial supply or major arterial supply give the segmental branches which make the network along the length of the esophagus. In the abdominal part, we have the arterial supply from the area of the left gastric artery, as you see here, and also we have the short gastric artery with the stomach and descending branches from the left phrenic artery. That means the arterial source of the diaphragm, arterial source of the fundus, and also the arterial source of the left part of the stomach. So these according to the different part of the arterial supply. The venous drainage in the cervical region, the main venous drainage through the inferior thyroid veins, and also in the thoracic region through the azygos and hemiazygos on the left side, brachiocephalic veins, and also the vertebral veins. That means on the left side and the right side, little bit difference along the thoracic region, azygos vein, hemiazygos vein, and also the posterior intercostal veins, which drainage into the direct or indirect through the azygos veins. Okay, then the abdominal part. The abdominal part, the venous drainage empty into the left gastric veins, and then the left gastric means, as you know, drainage into the area of the hepatic veins. So the venous drainage also, according to the different part and different location, has a specific drainage into the near adjacent major venous channel. The lymphatic drainage of the esophagus in the cervical region, the lymphatic drainage into the internal jugular lymph nodes and tracheal lymph nodes, that means parallel to the trachea, as you see here, okay, and posteriorly along this area. And then in the thoracic part, we have the posterior parietal lymph nodes and until to the level of the diaphragmatic lymph nodes. Then in the abdominal part, as you see here, okay, the abdominal part, the lymphatic drainage along the left gastric and also along the paracardiac lymph nodes. Then posteriorly passes through the depths to reach the para-aortic lymph nodes. There is, or during these courses from the cervical region downwards until to the abdominal area, okay, there is specific narrowing in the area of the, along the courses of the esophagus. We have the about commonly, or the major narrowing, we have about 3, or you can say 4 narrowing. First of all, we have the upper esophageal sphincters. The upper esophageal sphincters about the 15 centimeter from the maxillary central incisor teeth, so that when inserted the endoscopy along this area, when we have or when we reach this area, you can see the little bit sphincters in this area and stenosis in the area of the lumen of the esophagus downwards, so that this is a landmark and measurement to access through the esophageal, upper esophageal sphincters. And then we have the second narrowing area, this located at the superior border of the sternum, and this due to the crowding in the superior mediastinum or during the entrance of the thoracic cage, so that there is a little bit of stenosis by the crowding structure in this area. As you know that we have a lot of blood vessels and other structures in this area. So the third sphincters or the third narrowing, we have the aortic, made by the aortic arch, and about 22.5 centimeter after the maxillary central incisors. Then finally we have the fourth narrowing part, which is located across the point of the esophagus and the left bronchus. That means during, as you know, that the left bronchus has an oblique course, and then along these courses crossed anterior to the esophagus, and there is a little bit obstruction in this area, or the narrowing in this area and compression in this area, and this about 27.5 centimeter from the maxillary central incisors. And you can say that most inferiorly we have the another sphincters which is related to the cardiac sphincters. The cardiac sphincter, little bit sphincters to control the cardiac orifice between the esophagus and the stomach. So it's clearly we have the measurements along the esophagus until to the level of the entrance of the stomach. Do you have any questions? I think there is no question. And also if you have any question, you can send me on the email. Thank you for listening, and see you again inshallah.